Well, it's 12 o'clock Central Standard Time here in Austin, Texas. And so we'll go ahead and get the webinar started. Welcome, everyone. My name is Bridget Wallace. I am co-owner of 360 Neuro Health, putting on this event of What's in Your Clinic. This is our first episode. And I am also the owner of an outpatient therapy clinic in Austin, Texas. I'm a physical therapist, and I'm celebrating almost 22 years with this clinic. We have not all full-time, but we have 7 therapists, and we have an audiologist and specialize in dizziness and balance disorders. So pretty heavy on the diagnostic side of things, do a lot of, and then of course do a lot of rehab. And so when I got the idea about doing this, it was really, we do have a lot of technology in our clinic. We're really fortunate, but I thought I'm not going to probably choose something that people might expect from me, which is something vestibular, balance related. And I chose NeckCare because it's one of our newer products in the clinic. So what I'll do today is I'll kind of share a little background about my experience, but we've got 2 co-hosts on today's webinar, which is Orri, the CEO of NeckCare. And if you just hopped on, he's actually in Iceland right now. And we've got Dr. Cameron Bearder, a chiropractor, functional neurology practicing chiropractor, has a really unique practice in North Carolina. So I certainly don't want to be hogging too much of today's webinar because he actually has some case studies that he wants to share, and I'm super excited to have this connection with him. So welcome. I'll share a little experience. Being in the space, I was actually introduced to NeckCare from Dr. Jen Staskis, also was in this space. And, I've always, been vestibular and then really went into vision and kind of put my toe in the water on the spine and particularly the neck, but never under appreciating the importance, but really not taking that step to have more hands-on, despite more of the literature, the research coming out about the neck. We know it's been involved, but we've just been refer out. And so when I was introduced to this product, I was like, okay, I had the clinicians start using it, and we've really, we love it. We use the joint position error test quite a bit. I'm going to share a case study though we have staff meetings once a week and we review cases. And we had an interesting case, and we thought, what is the next best thing we can do if we're not think this is really vestibular? And as a team, we thought, well, we're pretty sure there's a visual component, but we thought this would be a good time to do what's called the butterfly test. And so I'm going to share a little experience around that. And I won't hog it all. Again, I'm going to let, after I wrap things up, I'd love Orri to introduce himself, and then really turn the floor over to Dr. Bearder and let him share some cases. So our new episode, What's in Your Clinic? Again, I'm kicking it off, but this is about reaching out to other practitioners and learning what you want to share, some kind of product, something you use in your clinic that you want to let others know about. So again, for this episode, I chose NeckCare. I'm going to unplug it from the little laptop here. So this is the headset with the IMU on the top. This is you can see it's quite portable. The way we use it in the clinic, we like stations instead of moving things around all the time. So we kind of have a NeckCare station that we know the laptop's there. If you can move it around though, it really depends on your clinic. But for us, we have a model that we have here's our balance station, here's our vision station, here's our neck. I don't think you can separate the neck, the inner ear, or the visual system. And maybe next time around, I'll be saying the whole spine, but I'm going a little segment at a time for me, coming so heavily from the neuro world. But these are easy tests to do an objective range of motion. And it has normative data to compare. We do the joint position error test, which is, we love the joint position error test. And so this was a nice way to see us objectify that. And the butterfly test was really new to us, but we are really appreciating the value of the butterfly test. And so just again, a story. I was introduced to NeckCare by Jen Stoskas, also vestibular therapist, been in the balance space and was really interested in this product. So we tried it. And then that got connected with Orri and other people associated with NeckCare. And as 360 Neuro Health, we really had this collaboration. And NeckCare has become actually one of our signature industry partners. I have to put a plug. They're not only in our platform 360 NeuroGo, and so you can learn more about them there, but they're featured. And this is this is my first book putting out about bedside clinical assessments and treatments for dizziness and balance disorders. But we also have some industry partners in the book that you can learn about who provide more objective. So the purpose of this book was really like, what can we do in the clinic and what objective tests are out there that can further confirm or, I love reports. I love technology. Not only because it objectifies and it allows us to have those progress notes, but patients love reports. When they actually can see, usually they kind of like to be out of normal ranges because they feel like, oh, you've just identified something. And they can relate it. Oftentimes this testing, we can always make a really great story about testing. They even want to know where the technology came from, whether it's SOT, why do you do this? Where did it come from? They are so interested in it. And I love to have create stories and connect with patients. And I think objective data, they love the reports and they love to see how it is further down the line. So it's not just about, it is important for us on the objective side and to monitor progress, but I find that it creates a great connection with patients to really get them tuned in once they see that report. And so I want to thank NeckCare for being one of our signature industry partners, your participation, and I look forward to not only using your product in the clinic, but collaborating on future events. So I won't continue to hog the time here because I want to obviously leave time for Orri and Dr. Bearder. But I thought, I had a kind of a plan. I might share some things, but then yesterday, we were having our weekly staff meeting and someone had shared a case where they were working with someone with kind of a high profile job, what they required, with dizziness. So they're referred here for dizziness. I had vestibular diagnostics, which was completely normal. So V&G normal, hearing test normal, VIMS normal, VHIT normal. And then the clinical exam was normal as far as the vestibular side. And so we have a tendency, we bring our biases to our exams, focusing on vestibular, and then oftentimes use that second visit, like maybe that's when we do more of the computerized testing, or that's when we do more, the use of NeckCare or taking that deeper dive in the visual component. So we have all different kinds of providers here, and we start our visits different, so you're going to hear our bias really coming from the vestibular side of things. But when we reviewed the case, so this was someone with dizziness, movement-related dizziness, no spinning. And so when I hear movement-related dizziness, my brain goes to the inner ear. When someone says, oh, as long as I'm being, still, I'm good, but it's when I'm moving, I'm thinking inner ear. I'm bringing my bias to the table. But that could be neck, right? Because what happens when we move? We're moving our neck, and that could be the visual system. But when I hear movement-related dizziness, I do think, this is probably going to be a VOR issue. But then, you start digging in and asking questions. And what it was is when he was focused and for long periods of time in this forward head position, focusing on a task, he was fine. And then, but when he came upright, it was like dizzy. So now that changes the story. That's very different than like, I'm here, brief rapid head movements, when we know that the vestibular system is highly dependent on and brief rapid head movements. That now I'm thinking, well, is there something going on where he's been in this prolonged forward head position? Now we've got an imbalance between the neck stabilizers. And think of the central visual focus. Someone's here doing very, fine motor skills for long periods of time. What they're not engaging in is their periphery. And so now when we think about what we hear as central binding, it's when our patients, they do this. They get it's central binding where all they want to do is process what's right in their central visual field. They don't want anything out here, but what happens in the periphery is what gives us so much visual spatial orientation. Where are we in space? So these are the patients that they don't like to be in busy places. They've got visually induced dizziness. And so that's one thing when we hear that, we want to think what is happening between their central and their periphery. So this to me sounded more like a case of we would need to take a closer look at the spine, the cervical stabilizers, not just the deep neck flexors, but the extensors. What is happening with the neck? And I am completely guilty and take full responsibility of spending so many years talking about deep neck flexors and not the extensors. And so, I get a few more years in me to kind of change that story. So I'm, spent most of my career, 30 years of my career speaking about vestibular and then adding deep neck flexors and then just smooth pursuit. And now I get to like move forward with what are we doing with extensors? What's the lumbar spine doing? And really it's exciting, right? Because it's getting me out of my biased box and looking at other components in the system as a whole, and really recognizing that every passing year how much I've missed, so that keeps me on my toes. So this is a different, approach. And yeah, we have team meetings about this because this isn't the space that we come from primarily. We come from really heavily, everybody here has so much training in the vestibular system and its associated pathways, but we don't start with the neck. We don't start with the visual system. Those are places we go when we're ruling out, we're not finding anything with the inner ear. So I'm super excited to hear about, from other approaches. And if there's any other NeckCare users out there, when we have time at the end to open up the floor, please share your story. So he's going to come back for his second visit. What are we going to do? We're going to do we're going to do range. We're going to get him on the NeckCare. We're going to do range of motion. We're going to do the joint position air test, and we're going to do the butterfly test. And so super excited. We're going to look more at the visual alignment. What happens with convergence in different planes? What happens when there is a task that requires central and peripheral integration? And you've probably, even if your patients are feeling unsteady and they're here, okay, so they go down and they just look at the floor. What are they doing? They're affecting the input from their neck muscles and not processing in the periphery. So we may find, maybe way past my time, I'm excited to be a part of changing the story, but where we start with the neck and we start with the visual system, because when we're in the best posture, it helps our eyes align best. So, if we treat someone here and just looking down and we do all this balance and their balance is better, we got to really question, am I doing them a service by not addressing these other things? Because that's going to become more problematic. And so what can we do kind of big picture to help them be in that most upright position? And so having this objective data, normative data, with the NeckCare system has been super exciting. If you jumped on late, just again, here is, you can see how portable this is with the IMU. So super excited, and I hope you start to have questions, think about questions, and maybe when you hear from Orri, maybe when you hear from Dr. Bearder, it'll give you other things to think about. But when we have vestibular migraines, oh my gosh, it's such a big part of our population. And so we need to be looking at the neck, where people with, whether it's, vestibular migraines, they have neck pain, they have limited range of motion, they have affected posture. This is an important piece, whether you're doing concussion, I wouldn't say we're a practice that specializes in whiplash injuries. Do we see them? Yes, we do, because people have dizziness afterwards, but people are coming to us. They're not coming to us with neck pain. They're not coming to us with any orthopedic issue. They're coming to us with dizziness, balance disorders, but we can't just look at the vestibular system. We have to be looking at the visual, and we have to be looking at the body as a whole. And we know that there's also a big psychological component to that. So knowing where our head is in space is super, super, super important. And those are the things that we look for before we even think maybe we don't need to do a VOR, vestibular ocular reflex exercise, because we've had some of those symptoms cleared by getting them in a better posture, teaching them to look more into the periphery and utilize that information. And sometimes that alone takes, helps their dizziness. And I've heard that story from orthopedic manual therapists my entire career. Like, I don't do what you do, but I do this, and so much of their dizziness is better. And yeah, this is an exciting time. I think concussion has really brought, where we're talking about vision, we're talking about the neck, and we're talking about vestibular more than we ever have before together, and I think concussion is what's going to help us bridge that gap. So super exciting. I'm going to turn the floor over to Orri, and you can say a few words again. Orri's the CEO of NeckCare, and he's in Iceland right now. Okay.
Great. Thank you so much, Bridget.
Mm-hmm.
And yeah, maybe we can have one in person in Iceland next time. We'll see about that. Yeah, pleasure to be here, and awesome to hear the success that you've had with the product in the clinic. And like Bridget, she had her charging cable in the headgear, but this is it. It goes on the head of the patient, and we like objective data, and we like objective reports. So you probably love your goniometer and doing your eyeball tests for range of motion, using the laser for joint positioner, but those days might be over, at least for all NeckCare customers. So we do have a mix of hardware and software. I won't do a full demo here today, but feel free to hit us up after the webinar for a personalized demo. But you can see here, it's a mix of hardware and software, and it runs on a web browser, so you can actually access it from whatever computer. My favorite demo patient is Michael Scott from Dunder Mifflin. What we first off we see is his history of all the assessments. So we record that and store that, but then also we can create new assessments. The assessments are consisting of range of motion, joint position error, and the butterfly test that Bridget has talked about, looking at obviously range of motion, proprioception, and then movement control of the cervical spine, that eye-head neck coordination, and the sensory motor integration. So very, very crucial for those post-concussive individuals, for individuals with balance issues, dizziness, and migraines, headaches, and neck pain, general neck pain. So that's what we do. I'm very much looking forward to hearing some case studies here from Dr. Bearder, and then the floor will be open for some questions. We have a team in Minnesota, our North American headquarters there, and then we also have an employee out in New Jersey. But we are listed with the FDA since 22. We hit the market in the US in 2023. And then, yeah, we've been hearing a lot of great interest from the market, and we now have customers in 8 different states. So it's an exciting time working with Harvard University on some research, University of Miami as well. Research is very important to us, and the company's actually started out of 20 years of research to standardize assessments of the neck. So that's where we come from, and we're very much looking forward to partnering up with even more clinicians and healthcare providers in the US. So
Hey,
on
Orri,
that note, Yeah,
Well, you know what would be great now? I think I just got a private message and I didn't explain the butterfly test. So if you want to
yeah,
just go over that so that people don't have to like, what's the butterfly test? And they can really listen
absolutely.
to Dr. Bearder share his cases.
Absolutely. So the butterfly test is an invention that's been 20 years in the making. A lot of research papers on it, so I encourage you to take a look at those. But what it essentially is the eye head neck coordination. And I'll do one path here just to give you an idea. What you will see on the screen is a red dot traveling on the screen in an unpredictable speed and direction. My job is to follow the dot with my nose. So I'm controlling a blue cross and I'm following it with my nose. So what you will need here is the sensory motor integration. My eyes need to talk to my brain and to my neck to be able to perform this test. And you should obviously not be talking when doing this. And this assessment was invented both as an assessment, but also as treatment. So this is a great exercise as well.
Okay, you've had some practice. You're
I
doing
have,
really well.
I have. And just to show you, this is a neurotypical individual myself doing this. And I will show you the report, how this actually looks like. We then get an objective report because we love data. So we now get a report, how well did I track that moving dot? So you can see here on my screen how well I do. We then compare that to normative data. So I'm definitely in the green here. We also do have indications on over and undershoot. If I undershoot a whole lot, that might be an indication that I have a difficulty in accelerating. I'm always behind. If I'm overshooting, it might mean that I have difficulty in decelerating. So it gives the clinician additional information, and that patient education that we hear about is super important. So some of our customers have described this as the signature of the neck or the signature of the eye head neck coordination. So my final slide here is hopefully answers the butterfly question, is an actual concussion patient. If anyone is interested in seeing how that will look like for a concussion patient. So I will share a report from an 18-year-old athlete, actually, where you can see here how they did. So pictures speak louder than 1,000 words, they say, and I think that's absolutely the true in this case. Any additional questions on the butterfly? Does it make sense?
Yes, that was very helpful. It's already generated some questions in my head that I'm probably going to be asking Dr. Bearder. I'm going to let him share his case studies though, but I am curious about some things already. So I really appreciate it.
Great. And then, yeah, Kelly Daniels asked if there are, different colors, different attempts. So yes, this individual did 2 attempts of each pattern. So we can see how they also do from a consistency perspective, doing multiple repetitions. That was that. Cameron, take it away.
Cool. That was pretty wicked. That was God bless that young person who, I mean, wow. I've seen some pretty bad ones, but that was really bad. Yeah, so my name is Cameron. I'm a chiropractor. I specialize in cervical issues, particularly the craniocervical junction, so the base of the skull. And most of my postdoctoral training has been in neurology. So through the Carrick Institute, which is basically the founders and the pioneers of functional neurology or chiropractic neurology. So I have fellowship candidacy status in neurology and vestibular conditions, and I'm working on the concussion one. So we see a lot of patients who have been a lot of other places, and that's kind of how I built my practice. Is actually now it's a requirement that you've been to at least 2 to 3 other doctors, so that we know that okay, we don't need to have to send you elsewhere because people have been on this journey. But so NeckCare kind of popped up onto my radar, not by accident, but randomly, and it was really funny. I was looking for one more thing. I have a force plate So checking posturography. I have right eye, which is looking at the neurovisual stuff. VNG was out of my price range at the time, but I definitely want one. But so I'm like, man, I need that proprioception, and I just don't know where to get it, outside of using the laser, which is great. You just can't necessarily quantify it. And then I saw a colleague post something about NeckCare, and I think literally within 5 minutes, I went to the website. I was like, let's go ahead and hop on this, and the rest is history. But I was blown away. Dr. Jen came and onboarded in office, which really helped a tremendous amount. But I started using it literally that I think within the next day or the next business day. And I've been using it every single day since. And it's been tremendous. It has helped me be a better clinician in terms of, like Dr. Bridget had said, looking at the eyes, looking at the vestibular system. When someone comes in and they have the VEMPs are good, the HIT test is good, the calorics are good. You're sitting here wondering, like, crap, this is clearly they're having vestibular symptoms, but they're not having true vestibular pathology. And so using right eye and then using NeckCare has helped me to enhance my understanding of each individual's unique presentation. And so from a chiropractic standpoint, because I know there's a lot of interesting things out there, there's a subset within chiropractic that is a little bit more specialized, and it's called upper cervical chiropractic or craniocervical junction procedures. And so these are folks who dedicate basically their careers to the upper neck, the craniocervical junction, C0, C1, and C2. And with this type of intervention, there's no twisting, popping, or cracking. So not the traditional manipulation, which sometimes has made it into the news, unfortunately, for some not so good things. But we use advanced imaging. So in our office, we use what's called a cone beam CT. So it's a 3D CT scan. It takes a full 360-degree image, 575 images of the head and the neck. So we can look at the entire head and neck structure and look for distortion. So we can call it joint position error, segmental somatic dysfunction, whatever you want to call it. But what we see, especially with dizziness patients, is we see these translations or these odd patterns in terms of structural malposition. And probably in 30% of the cases, when you look at their posture, they actually look somewhat normal. So that's always interesting. But what we then do is we use math, basically, and biomechanical principles to restore normal global alignment. Certain techniques will focus on segmental alignment, which is very important. But using these different pieces of tech, NeckCare has been able to enhance things even more tremendously. So I have told pretty much everyone within my group that this needs to be in every office, every upper cervical office around the country. Because we literally focus on the neck. So it, to me, makes complete sense that you would use something like NeckCare. Nothing like this has existed before. There's nothing that's existed putting all these three things together. You'd have to use three different individual pieces of tech. And then, of course, the reports and the data and, Orri and the...
Oh, no. Cameron's been having some technical issues, which he is completely frustrated about. And so I am going to, well, usually if he just kind of logs off and logs back on, but he was a little nervous about this. So I'm going to fill the space until we see him be able to come back. And Orri, I don't know if you're able to send him. I mean, I assume he knows he's frozen, but
Yeah.
if he doesn't, if you can send him a message. I'm going to bring up a concept here. So when Orri was showing the butterfly test and, undershoot, overshoot, and I'm going to out one of my friends and colleagues out there, Needy Seth, because she sent me a direct message. But for those of you in the neuro world, is when we see overshoot, undershoot, like I'm thinking of the eyes, I'm thinking of the cerebellum, And he's back, so I don't want to hog up too
Sorry.
much of his. No. I told him that you were a little frustrated. But one of the things I'm going to come back to at the end of this is I'm actually going to mention something that Needy Seth sent me a direct message on about how this reminds her of limits of stability testing, the butterfly test, and under and overshooting. I'm in love with the cerebellum, so anything to give me a reason to talk about the cerebellum. But we'll come back and address some of these questions. I want to take full advantage of Cameron having internet access right now and let him share some case studies. So it's yours. Did we lose him again? We lost him again. So Orri, I don't know if this is a question that you can answer. Has there been any research looking at, when you think about the butterfly test, it's almost like a full bot, like what we do in limits of stability computerized testing, voluntarily moving to a target, looking at an anterior, posterior, lateral, all these different movements. Is anyone's doing research in that? And comparing like how someone may do with body sway, like a limits of stability test versus the butterfly test.
Yeah, great question. So yeah, we actually have Harvard University currently looking at the relationship using our test and the butterfly in particular, and connect that to balance and in the elderly population. So looking at the fall prevention category. So yeah, we have also done some preliminary research on balance in particular, and how that's connected to the movement control of the neck.
Okay, we can see his screen now, so this looks good.
Yeah, this is me sharing actually, because Cameron shared this with me. But I think this is a very cool case study. Obviously, Cameron, maybe you can talk to it better than I can, but here you have highlighted some great pre and post of a patient.
Yeah. Oh, you grabbed it. Perfect.
Yep.
Awesome. So this was a vestibular migraine patient. She had seen a lot of folks, and she found us, I think, by accident.
Yeah, I'll take over. But what you can see here, what Cameron does very well with his patients is documentation, and so he has actually found some deviations in the butterfly test, and so the difficulty, the patient also had difficulty in the amplitude accuracy, so deviating left and right, but also up and down. So over and undershoot was it was not on target, and then also from the left and right, and he had indicated here the specific deviations. So Cameron, wanna give it one more shot?
I know, trying. Vestibular migraine patient. Basically, this was, I think, about 6 weeks in between. It was great, almost completely symptom-free. We did a combination of cervical proprioceptive retraining and upper cervical adjusting, and it worked awesome. She's
I will take over again, but it's great to see the documentation here, and patients have really loved this one. And I'll share another case study here as well, on the joint positioner. I don't know, are there many people on the call here that actually do the joint positioner with a laser? I'd love to hear that.
Yeah, please just say yes. JPE in our clinic. I
Yes.
recognize a lot of names on this call, so I'm gonna probably guess that a fair amount of practitioners use the joint position air
Yep,
test.
I can see the chat filling up. And so with the laser, obviously, we hear a lot that, okay, it's hassle to set it up. It is, no one really loves it to set it up. It's not accurate, and it's not recorded. So we don't record the movement. We're using Post-its or, markers on a piece of paper, Rob Lindell's chart on the wall. What we do is we have digitalized it, so you only have to wear the headgear, and then the patient closes their eyes, and they move left rotation, for example, and try to come back to neutral, and the system records that. So here on the top, you can see how a healthy individual looks like. This is like an example from Cameron that right rotation completely off. The individual so far off the charts that it didn't even hit the target. 8 weeks into treatment, they are within normal limits, green or yellow, for all directions. And to be able to document this in this way, in an objective way, has been instrumental to many of our customers, and to say the least, saving a whole lot of time and improving the patient buy-in, because they actually believe that this is a scientific assessment and not guesswork. So yeah, what do you think of this one, Bridget and others?
Yeah, I encourage people to share their comments. This is really, really amazing. We've all loved the ability to do the joint position error test in this way. If I think we're gonna encourage you, Orri, at some point maybe add a visual vertigo analog scale. I didn't mention it, but it also, and I think you may have seen it when Orri shared a screen earlier, but you can also rate their pain. Again, people don't typically come to us with pain, but a lot of our vestibular migraine folks or someone post-concussion, a lot of people do have neck pain, and not just that, the population that is bending forward on their computer all day. A large percentage of our patients do have neck pain. It's just not why they're coming to see us, but it's a real bonus that we feel comfortable adding this piece. So that was really nice. I can't imagine how frustrated Cameron is. We're all been in technology. I think for those of you that especially when he jumped on initially and his internet was working well, and you can see that he's very dynamic, and I think this is just going to be a bigger reason that we have to bring him back and hear something from him again, because I think he has a lot to share. So as we wait for him, I'm gonna make some assumptions. I'll tell you what we hear, or maybe questions we get on the therapy side, or working with other vendors in the space. And so many, and I'm a business owner, right? So I know that this is and there's so many advantages on the patient side, which is important, but I'm also a business owner, so I have to look at the return on investment from a financial as well. And I'm not here to talk about the pricing of it, but I'll just say what we do is we use the physical performance code, the 97750. And so we typically, when we think about all the tests we do, if we're running someone through the range of motion, the joint position error, and the butterfly test, and then going over that with them, we're probably going to do 97750 times 2. And that's how we bill. For us on the therapy side, we can't use 97750. And this is a question I get all the time when we do an initial eval. So if you remember, someone's coming here on the vestibular side, that's going to be our primary focus as far as our evaluation. So it's not uncommon for us on a follow-up visit to utilize the NeckCare product, or that's when we do our computerized balance testing when we're using technology. Now, let's say I get someone that's just like flying through an exam, everything's really, they're higher level, then maybe I'm going ahead and doing that computerized. Maybe I'm doing the modified Cobalt for concussion, or maybe I'm doing the NeckCare, or maybe I'm doing the sensory organization, computerized dynamic posturography. So there are times that, yes, I go ahead and do it on the initial eval, but it's just a common question that people get. Well, how do I bill for it? And 97750 is a nice code to use in this situation.
And to add on that, just from other customers and third-party billers that we have talked to, 97112 neuromuscular re-education is also being billed for it, and 97110 therapeutic exercises. So as the assessment is the exercise, if you will, for the sensory motor integration and neuromuscular re-ed, those codes have been billed by many of our customers as well, just FYI.
Yeah, and hello, Kelly. Welcome. And congratulations on being a licensed physical therapist after so many years as a PTA. So it's good to see you back in this realm of things and participating in these events. Unfortunately, we haven't been able to get Cameron back on, but that's something we can ask him. How many times a week was this patient coming in? There's other ways without a laser to have people do kind of range of motion things. It takes a little bit of work, but like we keep safety glasses here. We use it for what's called binasal occlusion, but another way we use it is we tape glasses like with both sides, and then we create a small pinhole on one side, just a tiny pinhole where they can like see see a target. And what we do is we have them track the target with that eye so they don't have to mess with the laser. So there's other ways you can have people do things at home. It usually takes a little bit more work, but maybe you're having them do postural work at home, working on the extensors or the flexors or range of motion. So many of the patients we see are impaired in those areas. Can he video record his presentation and send to you and put up in the hub? That's a great idea. I think we could ask him to do that. It's brilliant. So thanks, Joan. I know he was really anxious to go over some case studies, and this is inspiring, for us as well, because we see so many people with vestibular migraines. And even a colleague here of mine in town, Angela Rich, who's a professor at the PT school, was in private practice. She's been a part of our education. She and some students did a study where they did joint position error, cervical range of motion, manual therapy techniques with someone with migraines, and how much it helped their dizziness, their balance, some of the other symptoms they were coming in for. So I think it's a really exciting time for us on the vestibular neuro side to really jump into this world of vision and neck. They, again, can't separate those systems. And then Orri, I guess if we're not going to get Cameron back, I just want you to keep your questions coming. But is there any other research that you're looking at on your end? I know a lot of folks are interested in concussion. I think it's real easy to see this fit. I'm super interested in looking at sway on posturography and then the butterfly test now that I've seen this, and then maybe ocular motor under overshooting and the butterfly test, and seeing from the visual and from posturography if there's any correlations in that. But welcome anything else you have going on your end that you want to share.
Absolutely. So we have, we're very dedicated to research. So I encourage you to go to neckcare.com/research as well. You can see 20 years of different papers. And then we are working with several universities in the US on different elements. So very excited about that. And then recently partnered with Dr. John Letty out of Buffalo. So he is, wonderful human being and a very smart individual, and to get his expertise on concussion. So he will be studying concussion and using some of our technology when doing that.
Oh, that's going to be nice to see all the exertional and now the neck coming together. So that's exciting. Do any of you out there, we've had some people share that you can follow his case studies. Al's sharing some information. We do see he's back. Okay. All right, go ahead. You're muted. Let me unmute you.
Can you hear me now?
Yep.
Yes.
Perfect. Different computer. All right, so let's pop this up here. We should be good to go on this one. So essentially, I've been using this in various ways. I've been using this in different capacities for various cases. And what I've found is that So this is a joint position error. And I have ideal up here and then the patient before and the after. So this was a chronic neck pain patient. They'd seen quite a few folks over the years, mainly chiropractors. But you can see that before is pretty nasty. So for reference, joint position error is a relocation test. So you have the eyes closed, you bring your head down, bring it back, you do that 3 times, you go extension and then rotation. And so the data shows that they should be within about 4.5 degrees, I believe. And so that would be the green. And the patient did horrible for all of them. Right rotation, they weren't even within bad. So we did some care. I believe this was about maybe 4 weeks. And we did a combination of proprioceptive retraining and chiropractic upper cervical adjusting. And then we retested, and you can see, and almost all of them, they're tremendously improved. Extension was great. Left rotation was a lot better. Actually a little bit worse. Right rotation was actually on the map now. And importantly for the patient, they were, for the most part, pain-free and symptom-free. So, but what I've seen in particular with, at least in the data, and I thought this was very interesting, the data is apparently supporting more of the fine motor control in terms of being more comprehensive. And so, for example, this one, you should be able to see that. But so this is obviously fine motor control. This is a different patient. But what I found using NeckCare, and I didn't know this beforehand, what I found is that sometimes the data doesn't show between joint position error and fine motor control. It doesn't show the same thing. So in theory, if there's a joint position error, there is probably going to be a fine motor control error. And I haven't seen that consistently. And so that's led me down the path of, all right, what are we doing? What are we looking for? But I still apply the intervention, and we find that folks tend to get better. So this was a post-concussive patient, and I believe this was about 4 weeks. So this one, was pretty gnarly as well. And the thing I love about NeckCare is and the patients don't know this, but we know this, the easy, the medium, and difficult, it's going at different speeds. It's going at different velocities. And so when you look at this easy, you can see how tremendous it's moving slow and it's moving around here. One of the things that I love to see in particular is this little snippet right there. That's where they're supposed to be moving very slow. And as we saw in that 18-year-old case, this person did pretty good, but that person on the 18-year-old case didn't do very good. This one, actually, I love looking at this one because that one tells me really how much, in that if they can't even hold their head smooth and slow when they're going slow, who's to say that they're going to be able to do that when they're moving fast? And as Dr. Bridget said before, that one particular patient that you had been treating, they were steady, right? So they were holding their head steady. If a patient can't even do that, to me, that data is invaluable. Like you can't put a price on that. To be able to tell a patient, hey, you're having trouble across the board. We need to get you to the point where you can just hold your head still. Because a lot of these folks, especially with like a concussion or a movement disorder, concussion, frontal lobe, basal ganglionic, cerebellum, they're kind of sitting there, they're titubating a little bit. If you can calm that down, that's going to calm everything down. So that data, I don't even think the Carrick Institute has seen data like that before. So to be able to have that through something like NeckCare and be able to track it and show improvement, it's just been it. And I hate to use this phrase because it's so cliche, but it truly has been a game changer. It has changed the way that I practice. It's changed the way that I treat. And it really shows you what's working and what's not, which I think is tremendous for a practitioner. And it's extremely humbling. We're taught certain things and we follow protocols and we do our stuff, but to be able to see, okay, this is working versus it's not working, it allows you very quickly to be able to change course or modify course so that patient isn't stuck in your office or has to go somewhere else over a period of time, if you're humble enough and if you're willing enough to look and say, okay, what I'm doing isn't working, we need to change this up. I think that that's a win-win across the board for clinicians and patients. But in terms of other stuff, it's I do have other things. They all look similar in terms of we just compiled the data. This one I do like as well, because sometimes you have folks that things look good, but then you go and you look at the data, and this one thankfully did look good. But so you can see here with the amplitude accuracy, amplitude is going to be the deviation left and right, whereas directional is going to be that on target, over target, or under target. And so here we have the pre on the left, and you can see they're in the yellow trending into the red. And then post treatment and evaluation, you can see that now they're trending green and into the yellow. And then again, with directional accuracy, as it got worse, they got worse, or as it got harder, they got worse, and then things got better. So sometimes I found as well, looking at both, looking at the tracing, but then comparing it to, because sometimes you'll look at the tracing and like I'll look and think, crap, this didn't look like it improved that much. But if you're only looking at amplitude, you're missing what, 50% at least. You're missing 50% of the equation. And that being able to show that there was an improvement in being on target, that's a whole nother ballgame. Because I mean, how does a patient know if they're on target or not? Right? How do they know? Oh, I know that I'm following this. They have no method to track that. But now if we can have the data to show that there was improvement, even if the tracings didn't look better, so to say. And I know that Orri and the NeckCare team are working on something behind the scenes to be able to show the tracings, which is going to be a whole nother ballgame. But yeah, this has changed the way I practice. It truly has. It's made me more of it's going to sound very bad, more of a humble clinician in terms of, patient feels better. This is great. But then you go and you look at redoing the data and you find that, oh crap, there was about a 20% improvement, which is good. They feel good on 20%, but we're looking for, and Doc, I know you can agree with this, we're looking for that long lasting change. We're looking for that, that longevity of, okay, they feel better and things look better objectively, so that we can sit back, we can sleep at night and say, we did our job, and they're going to do better. They're going to do good for more than just, the time in between office visits, which is always interesting. But
thank you. That was super inspiring. And I love, I love the relationship, and this was not intended. And that is, I love when things happen organically, right? Is that on the, posturography side, when we're looking at limits of stability, we're looking at postural sway. And I love the summary reports. They're so nice to show patients, but it's really the raw data that when you go back and look at that is so valuable, because you can see this composite score go up, but then when you look at a sway pattern in balance, it's all over. It's all over the place. And so this is what inspired me to, when we lost you for a little bit, what we were talking about is, is the use of the word undershoot and overshoot, and you use right eye. We're doing V&Gs, we're looking at that. Are we going to see correlations? Because we, love the cerebellum.
Yep.
And then when we're looking at that sway on the posturography, what's that raw data? How's it comparing? I think it's really interesting. I don't even know what a clear clinical question is, but I think it's enough for me to start digging a little deeper into what is correlating here.
So the research shows that because at least the research that I have compiled from PubMed has shown that typically with neck issues, you're going to have that postural sway. So I think even just doing an in-office data compilation of neck care and posturography to be able to show, hey, this is a neck issue, but it's literally affecting your entire postural system and balance system. I mean, that's easy stuff. Like that's easy data to accumulate. And the same with right eye. One of the things that I've loved about neck care is that when someone has great joint position error, but their fine motor control is crap, I'm thinking, okay, I have to go and I need to look at pursuits. I need to look at saccades. I need to look at these neurovisual pathways, because the huge difference there is eyes open, eyes closed, right? Joint position error, your eyes are closed. Fine motor control, your eyes are open. So we're assuming that there's a great synergistic or integrative relationship between all of these systems of the brain, the eyes, the inner ear, and the neck. And having that data and having the other tools to be able to correlate that, I think, is something that is untapped. But I do see the limitations in that. You have, I mean, these tools is cost prohibitive. To me, that it's worth the money to be able to say, okay, NeckCare tells me, joint position error tells me everything looks good. So now I know I need to work on more of the integration of these three systems. So I need to take a comprehensive approach to treatment, as opposed to just having them close their eyes and just do this again and again.
No, it's really a great point. Do you happen to know Deanne Fitzgerald, optometrist? We've got to get you connected.
That sounds familiar.
Yeah, we really got to get you connected with her. So she's really been a pioneer, and neuro-optometrists have just inspired me on the vestibular side. So we do so much on vision now. And, she's really the one that said, think about what is gaze stability. Because in the vestibular, we think about gaze stability with the head moving, with the head still first.
Yep.
We need to see what they can control. And then we move out into the periphery, and then we move the head. This kind of really inspired the progressions of just what you're saying. And that's why I think y'all would have, and she uses right eye as well in her practice. So I think there would be a lot of synergy. So we've got to do, we've got to do a follow-up for sure.
Yeah. Yeah.
Well, we ran out of time, but we had a question, Cameron. Someone was curious about, I think it was the one with vestibular migraines, that someone was asking how many times was there, like, did you see him twice a week, 3 times a week? Did you see him? Yeah.
Yeah. So we don't do traditional care plans like chiros do, or even, we don't do traditional care plans. So I do an initial trial period of care. Research says a particular range of time. So for neck issues, at least for certain things. So we do 6 weeks, and we do 2 times a week.
Okay.
So twice a week, probably on average about 30 minutes per. And so a lot of what we do here at Keystone is active rehab. It's not passive stuff. The only passive thing probably is the chiropractic upper cervical adjustment. But Doc, I'm sure you would agree, and any practitioners on this, a lot of this heavily relies on patients doing their homework at home.
Yes, it does.
God, that's, man, if people did their homework, my practice, I'd have a year-long waiting list.
Yeah. Yeah, that was actually a question. Someone said, are you having them do exercises at home?
Yeah, and that's it depends on the case. If we have a lot of neurovisual, so if I see gaze instability with right eye, because their head is straight, there's 3 different targets, it's 7 seconds looking at each. If I see gaze stability, I will probably give them some sort of, home VOR stabilization exercise just to kind of prime the pump. But I've seen, and again, having this technology, we'll do pre and post gaze stability, saccodometry, pursuits with craniocervical adjusting. I'm actually going to be doing a presentation in Orlando on this, because some of the things that we've seen in terms of stability of the neurovisual pathways after craniocervical junction manipulation, it's mind-blowing. Into maybe they don't have to do as much at home because we were able to stabilize the system in a different capacity. I still have folks do things like, doing a little bit of VOR, gaze stability at home isn't going to hurt them. But yeah, it's what they do out in the real world, I think, matters more than what happens in here over a long period of time.
Well, I hope that we can collaborate on you doing some future webinars for us, because this was way too short, and I can tell that you have so much to share, and I have a feeling that others feel the same way. So
I'd love to.
I'm really glad our paths crossed. And we'll close this out. It was recorded. We'll do a little editing here and there, and then we'll let you know where it's posted.
Sure.
If there's anything other resources that you want to share regarding your website, or someone had posted, I think it was Al had posted about your Instagram page. Certainly want to get people connected to what you're doing. I'm going to do another plug. We're sending out this new book that I just put together on bedside assessments and treatments, and we have treatment progressions in there. And thank you, NeckCare, for being one of our signature industry partners. Please, if you didn't have time to get a question answered, for those that are watching this as a recording, send questions. We'll get you connected both to Orri or to Dr. Cameron. So thank you all so much. Thanks for your participation, and let us know if there's anyone out there who wants to share what's in your clinic, because this isn't about, I'm not going to do this every month. I can host it and I can be a moderator, but I really want to hear what other people are doing out in your clinics for people with dizziness and balance, concussion, anything kind of related to the vestibular visual space, neck space. All right. Thank you all so much.
Thank you.